As you go.
Hello, I'm Hela Lezetica and I will be the moderator for the following presentations, and I want to welcome you to the last but not least live in a box session at Surgicon 2020. Today, we are honored to talk about cardiovascular surgery with four of the best cardiothoracic surgeons and cardiologists in Romania and Italy. For the first presentation, let me introduce you Dr. Horia Muresian, a cardiovascular surgeon and anatomist with international medical and scientific experience. He is an awarded doctor in Romania, United States of America, and Italy, and is the forerunner of new techniques in coronary surgery and valvuloplasties. Dr. Muresian is also the founder of the Cardiovascular Dissection Center in Milan for the study of clinical anatomy and surgical techniques, and today he is presenting us the surgical anatomy in mitral valve disease. After that, we have the pleasure to talk about perioperative echocardiography in mitral valve prolapse with Dr. Gheorghe Cerin, the head of cardiology department at San Guadenzio d'Italia Hospital and Doctor of Medicine cum laude, a degree obtained at the Carol Davila University of Medicine in Bucharest. Member of the European Society of Cardiology, Dr. Cerin has been awarded countless prizes and medals, including a distinction offered by the Romanian Academy of Scientists for outstanding contributions in the field of cardiology, cardiovascular surgery, and training young specialists. Dr. Theodor Cebotaru is the head of the cardiac surgery department at Monza Hospital and the most experienced surgeon in Romania in beating heart surgery and mitral valve surgery. Dr. Cebotaru is the promoter of cardiovascular surgery with the help of surgical robots, together with his team performing the first interventions of this type in Romania and in Southeastern Europe. Today, he will be teaching us about the surgical approach in mitral valve surgery with the help of a live-in-a-box case presentation. Finally, it's a great honor to introduce Dr. Marco Diena with the presentation Sternotomy versus minithoracotomy in mitral valve repair. Dr. Diena, head director of cardio team, graduated at the University of Turin with full honors, and at only 35 years old, he became the youngest heart surgeon chief in Italy. With the experience of more than 20,000 cardiac surgeries, Dr. Diena is considered an international benchmark in the surgical treatment of adult heart disease performed with minimally invasive approach. Without further ado, doctors, if you're ready, let's start the presentations.
Good morning to everybody. I would like to start with some introductory remarks regarding the mitral valve and the cardiac surgery. In the meantime, you will see some images from a PowerPoint presentation regarding the clinical and surgical anatomy of the heart in order to introduce you more in this particular topic of the mitral valve as we see it nowadays. I would like to start with some assertions regarding the fact that no more than 40 years ago, all that we knew and learned about the mitral valve was that it consisted of two leaflets, two papillary muscles, and two corresponding commissures. The most prevalent disease was rheumatic mitral stenosis, generally affecting younger patients who developed huge left atrial enlargement, secondary pulmonary hypertension, atrial fibrillation, and very often systemic embolism due to left atrial thrombosis. The prevalent cardiac operation in those days performed was mitral commissurotomy in closed heart surgery, and the valvular substitutes and the prostheses continuously developed, but initially these were far from being perfect. The mitral valve replacement has followed, but still with a higher rate of complications and mortality. Little was known about the complex architecture and function of the mitral valve and not least of the left ventricle. A major step forward was represented by the technique of mitral valvoplasty reconstruction promoted by the Professor Carpentier in Paris. Beside mitral stenosis, the technique addressed mitral insufficiency also. Carpentier was also the first to classify the types of mitral regurgitation and elaborated particular techniques for each type of disease. As a consequence, a reciprocal collaboration between surgeons and echographists started and developed, becoming also a source of inspiration for future scientific research. Advantages and major gains in knowledge accumulated on both sides for the benefit of patients. Today, we understand better the mitral valve, although not completely yet. As you will see, the current view is that of a mitral valvular complex, including the valve leaflets displaying different scallops, the tendinous cords variously classified with respect to their role, papillary muscles, the mitral aortic curtain, the left atrial and left ventricular endocardium and myocardium. The anatomy and physiology of the mitral valvular complex, both in normal as well as in disease, is intimately correlated to those of the left ventricle, including the vascularization. The anatomical knowledge displays new valencies and opens the door to further clinical and basic science investigation. The newly developed diagnostic techniques and the surgical approaches demand a thorough knowledge of anatomy. The initial approach of Professor Carpentier was to render an anatomically perfect restoration of the mitral valvular complex. Nowadays, knowing the diseases and the natural evolution of the mitral valve disease, we have come to understand that surgery must create a physiologically suitable valvular complex and not a perfect valve. New advances and steps forward have been accomplished, especially regarding the ultrasound examination. Surgery has moved toward new technologies, including the robotic approach. However, between the median sternotomy, the classical approach, and the robotic, there are also numerous minimally invasive approaches. In today's session, you will learn about the state of the art regarding the anatomy, the diagnostic, and the surgical treatment of the mitral valve disease. I will start with a presentation that has been registered, recorded as a video presentation. Just a moment.
Thank you, Horia. Very nice introduction.
Just one moment, because I have to.
Yes.
Sharing. I have to close this. Okay. Less than 1 minute. Okay. So this will be the one.
Good evening to everybody. I'm Dr. Horia Muresian from the Cardiovascular Department of the University Hospital in Bucharest, and I have pleasure to present you the surgical anatomy of the mitral valve. I would like to start with an assertion. With the advent of modern diagnostic imaging tools and following the advances of surgical therapy, the classical image of the mitral valve has changed. Beside the well-known components, the annulus, the valve leaflets, and the subvalvular apparatus, the new concept of the mitral valvular complex also includes the left atrial and ventricular myocardium, endocardium, and the mitral aortic curtain. The particular disposition of the mitral and the aortic orifices is that of sharing the base of the left ventricle. Consequently, the anterior mitral leaflet alternatively delimitates the inflow and the outflow compartments of the left ventricle during the cardiac cycle. The mitral valve must allow the passage of the blood from the left atrium into the left ventricle, must ensure the tight systolic closure of the atrioventricular orifice, and not least, the accommodation of blood and its ejection through the left ventricular outflow tract. Consequently, the mitral valve is not solely an atrioventricular valve, as it takes part in the makeup and function of the aortic root too. The valve leaflets are a continuous, uninterrupted structure. No commissure or cleft will normally reach the level of the annulus. Moreover, the valve is funnel-shaped, a form that becomes more evident in mitral stenosis. It is also important in this latter situation to precisely determine the area of the valvular orifice during echo examination, as this area depends on the cutting level of the ultrasound beam. The posterior or mural leaflet usually depicts 3 scallops, while the anterior is undivided. Each leaflet consists of a rough zone where coaptation takes place, a clear and a pliable zone, and, characteristic to the posterior leaflet, a basal zone where basal cords reinforce the posterior annulus. Although the anterior leaflet is undivided, 3 portions are named in correspondence to the scallops of the posterior or mural leaflet. Consequently, 3 pairs of scallops can be defined echographically and surgically, A1M1, A2M2, and A3M3. The various patterns of mitral regurgitation can be precisely defined while referring to which and how many of the 6 scallops are prolapsing. The status of the commissures must also be added to the diagnostic picture. The anterior mitral leaflet corresponds to roughly 1/3 of the annulus, while the remainder 2/3 to the posterior mitral leaflet. After annuloplasty, this proportion is changed, and the surgeon must calculate thoroughly and ensure a balance between the remaining leaflet material and the annular area in order to obtain a good coaptation and to avoid the SAM. The mitral cords can be classified as follows. The free margin cords provide coaptation. The rough zone cords maintain the geometry of the leaflets during the cardiac cycle. The strut cords maintain the ventricular geometry and act as active ligaments of the left ventricle. The basal cords secure and reinforce the posterior annulus. The valve leaflets coapt under the annular plane, while the leaflets also overlap for about 6 millimeters. The resulting coaptation triangle and surface must be correctly rendered during valveplasty. The main modifications leading to mitral regurgitations are illustrated: cord elongation or rupture, intercaudal leaflet widening or hoodening, and leaflet perforation. The fibrous tracts of each cord proceed within the leaflets, most of these intermingling and forming the rough zone of the leaflets, while others can reach even the annulus. Hence, the significance of chordal rupture depicts numerous individual variations. The total leaflet area exceeds by 1.5 to 2 times the annular area. The standardized annular area is above 2.3 square centimeters over square meter of body surface area. This reflects the functional reserve of the mitral valve. The area of the mitral aperture is approximately 2/3 of the annular area. The normally oval aperture of the mitral valve becomes crescent-shaped after annuloplasty. Although not strictly planar, the annulus is ovoidal in shape with a longer intercommissural diameter over the aortomural diameter. Normal values are given in the slide. The normal asymmetry of the mitral valve. The mitral valve depicts a natural asymmetry. The cords from the posterior papillary muscle are slender, longer, have a more oblique course, and sustain portions of the leaflets that are thinner and with less height. Viewed from the ventricular side, the cords, including the strut cords, are not equally distributed over the 2 imaginary halves of the leaflet. This is displayed in the case presented with a prolapse of the A2 scallop due to rupture of cords with origin in the same posterior or inferior papillary muscle and not in both papillary muscles. Ischemic mitral regurgitation, on the other hand, may develop with papillary muscle rupture, a condition requiring mitral replacement and associated with high mortality, or, in case of acute myocardial infarction, being produced by dysfunction of the papillary muscles and the posterior left ventricular wall, or in case of chronic cardiac disease with normal resting ventricular function but accentuated with exercise, or in end-stage ischemic disease and ventricular dysfunction by distortion of the subvalvular apparatus. Besides the acute and chronic deleterious effects of the left ventricular myocardium and papillary muscles, ischemia may also produce atrial ischemia or infarction and nodal tissue ischemia, conditions that complicate the clinical picture. The strut cords and the papillary muscles can be looked upon as active ligaments of the left ventricle, with important components inserting not only on the leaflets, but also on the left and right fibrous trigons of the heart. This is exemplified by the fact that the left ventricle assumes various configurations in mitral insufficiency due to architecture and disposition of the papillary muscles. The cases are different with 2 papillary muscles, 3 papillary muscle heads, or an almost continuous structure of the papillary muscles. The diagnostic interrogation must evaluate not only the tenting area, the leaflet coaptation, the annulus, but also the left ventricle. The surgical maneuvers are consequently multiple and must address all components when indicated. The alteration of the entire mitral complex is evident in ischemic dilated cardiomyopathy. The left ventricular tuberculae and the papillary muscles become thin, flattened, and displaced. In large areas, the myocardium is replaced by fibrous tissue. The greater stress during the mitral closure is borne by the posterior leaflet and the posterior left ventricular wall, the portion responsible for the sphincteric mechanisms, which under normal circumstances allows a 23 to 40% variation of the annular size. This explains the more frequent rupture of the posterior mitral components. The interdependence between the posterior left ventricular wall and the posterior medial papillary muscle group of the mitral valve refers not only at their common vascularization, but also to the anatomical disposition. The origin of the papillary muscle resembles the roots of a tree. In the specimen depicted, areas of endomyocardial fibrosis and thinning are also shown by arrowheads. A displayed mitral valve, in this particular case with 4 scallops of the posterior leaflet and multiple heads of the posterior papillary muscle. A muscular arch, indicated by arrowhead, between heads gives origin to cords sustaining the middle scallops. This disposition explains cases when ischemic rupture of the posterior papillary muscle are not immediately followed by mitral regurgitation. A demonstration of the basal cords which reinforce the posterior annulus. The posterior papillary muscle group was detached from the ventricular wall. Base relief-like trabeculae and stout cords insert on the posterior annulus. Excessive decalcification on this area during mitral surgery may lead to atrioventricular dysfunction. Numerous fibrous structures link the papillary muscle heads to each other and with the fibrous trigons of the heart. The mitral annulus is attached to the base of the left ventricle all around except the septum, where the mitral aortic curtain continues towards the aortic root. The vascularization of the papillary muscles depends on the coronary dominance, with the posterior group being vascularized either from the right or the left coronary artery. The border zone between the territories of the 2 coronaries represents a delicate area, as these vessels are the most distal from their aortic origin, the most distal as order of bifurcation, and much more dependent on the parietal tension and intracavitary pressure. The vascularization of the posterior papillary muscle and of the posterior left ventricular wall depends on such smaller arteries, explaining their more frequent damage in ischemic heart disease. Taking into account the fact that on one hand the leaflets, cords, and papillary muscles depict a natural asymmetry and individual variations, and that on the other hand the coronary arterial distribution shows individual variations, and that the left ventricular shape and volume besides individual variations also demonstrate a particular individual reactivity, it appears evident that the mitral valvar complex will display various patterns under stress and not least in disease. All these details underscore the necessity of a thorough and selective diagnostic workup and therapy for each patient, while opening more doors for further study in clinical and surgical anatomy of the heart. Thank you for your attention. Good evening to everybody.
Thank you for your presentation, Doctor. We have some questions from the public. First question is, what is the best way to explore the anatomy of the mitral valve from a research point of view?
What is the, can you repeat?
What is the best way to explore the anatomy of the mitral valve?
The best way is to do by yourself the anatomy, because I have started doing these dissections by myself, including the photographical recording, because I didn't understand much, or I didn't understand anything at all about the cardiac anatomy, because the heart is an asymmetrical organ. It is very difficult to have it dismantled during operations. So you will not see all the anatomical relationships and all the particular elements of the heart. So it is mandatory to perform dissections on both formalin fixed and fresh human hearts. If not available, the pig heart or the ovine hearts, and not least experimental surgery. I did also experimental surgery on smaller animals, and this is very fruitful experience. So I should say reading, studying atlases and so on, virtual imaging and 3D reconstructions and so on, but you will never get the particular approach unless you will perform by yourself the dissections. I have to tell you also that most of the most skilled cardiologists in ultrasound examination, both in Italy and in the United States or also in Romania, I have the chance to know and collaborate with, were people who were present in the operating room, but also in the autopsy rooms when patients deceased. So it is mandatory to have the direct contact with the anatomy, but the anatomy represents only the first step. You should see also regarding the ultrasound examination, the MRI and the CT scanning and so on, that everybody has to know very well the physiology, the biochemistry, the electrophysiology and so on. So the anatomy, if you see it here, it's only the first step, but you have to have it thoroughly, thorough knowledge of anatomy.
Okay, thank you. And we have another question from Anna Maria. Are risk factors for developing such a condition only genetic, or do other things contribute to the degeneration of the valves?
No, mostly they are not only genetic, they are also acquired. Mostly are acquired nowadays. Not only the rheumatic heart disease, but also degenerative heart disease, ischemic heart disease, and so on. So it's a very long chapter to tell you about that.
We have problem with the audio, Horia.
Well, could you hear that, my answer?
Somehow, not very well. Please.
No, not only genetic, but there are also very many acquired heart conditions that can affect the mitral valvular complex. And here I'm referring not only to the valve, but also to the subvalvular apparatus and the left ventricle.
But also it is a problem of somehow genetic, because the composition of the tissues are depending on the genes of the person. So we observe that there is a familial aggregation of degenerative mitral disease in Barlow patient or in Marfan patient. Probably Horia Muresian, Marco Diena, and you will confirm me that there is somehow the frequency of the mitral prolapse in a family with a mitral prolapse is higher respect of the other people, because the amount of elastic tissue, or maybe the quality, the type of elastic tissue or collagen tissue depends by the genetics.
Yes, but it's not a straightforward cause-effect relationship. It's a predisposition. Yes, in some cases, yes, but many are the responses to various stresses during lifetime and some additional minor diseases that can affect the mitral valvular complex.
Okay.
Okay, thank you, doctor. Dr. Cerin, if you are ready.
I think so. I have to divide probably the, just a moment. I cannot share the screen, why? Probably now you can see.
It's okay, yes.
Yes, thank you. So in the next 30 minutes, more or less, I will try to share with you some the experience of our center in Italy and in Bucharest regarding the mitral, degenerative mitral valve, Barlow disease, prolapse of mitral valve. And I will start my presentation with an overview, because the medicine is changing and you are young and you have to face this rapid transformation of our job. I remember that I was young and student as you, it was only possible to perform surgery in a patient with mitral valve insufficiency, putting a prosthesis, a mechanical or biological prosthesis, or maybe to repair the valve. But we assist in the last decades of the rapid transformation of our job. And I remember the first cases with mitral stenosis and treatment of this patient in interventional cardiology with balloon valvuloplasty. Then I remember Professor Alfieri from Milan, who has been, I think, last year chairman in New York Congress in Bucharest, having this clever idea to suture, to stitch the anterior and posterior leaflet. And from this idea, we remember the mitral clip. Then another Italian in Pittsburgh, Giovanni Speziali, who has this clever idea to use on beating heart the possibility to put the cord. And nowadays we are facing a lot of interventional procedures as paravalvular leak closure, valve-in-a-valve procedures, or cardioband annuloplasty, or in the last 10 years, more or less, cardiac surgery. But where is my message for you? No one of these cardiological interventional procedures or surgical procedures can be done without an echocardiography, and which in the everyday practice is a transesophageal echocardiography, and only sometimes intracardiac echocardiography. Probably your generation will benefit more from intracardiac echocardiography because the price of this proof will decrease on the market. And this means that we change not only our way of doing medicine, but this method, the technology, the development of technology in medicine shows us that we change also the role of the people. The cardiologist who has been only a clinician with a stethoscope doing anamnesis and giving pills in the ambulatory or in the ward, nowadays became a person with a very well-defined place in a heart team. So it's not you as surgeon, you must be aware of fact that you have to be able to work in a team, and you must know something about echocardiography, as cardiologists must know something about your surgical technique. So on my presentation for today, I will deal principally about assessment of the patient candidate to cardiac surgery in mitral repair. Let me share with you the experience of our center in Novara with Marco Diena, and in Bucharest with Dr. Cebotaru. And but first of all, I want to invite you in Bucharest, the place of this interesting meeting, and allow me please to remember that when I was a student, I started to do medicine in this nice hospital, which was built 300 years ago. My message regarding the medicine is that you must know internal medicine. It's not possible to do high level in cardiac surgery, or doesn't matter which kind of surgery, without knowing internal medicine and clinical medicine. So, as Horia Muresian show us, the echocardiography allow us to see the mitral structure, but also allow us to see the mitral function, which is not possible to assess by the surgeon intraoperatively. And also it allows us to understand something regarding the geometry, which seems to be something as a theoretical concept, but this insight in the everyday practice is a very important concept. And based on this information, we will choose the strategy, which may be in some cases surgical strategy, or maybe interventional cardiology. And this is possible because in 1953, two men, Professor Inge Egler from Switzerland, and Professor Karl Hertz, a physician, discovered this signal. Now, one of them were probably imaged that this image will allow over time to obtain some fantastic images. And the second important moment was discovering of of the Doppler echocardiography. So this one is possible, was possible because of the huge development on computers. This is the first computer, this is the first echocardiographer, and this is one of the mobile echocardiographer available on the market in the last 15 years. So Doppler echocardiography was the second step, as I told you, and this is the first Doppler machine. This technique allows us, using modified Bernoulli equation pressure, avoiding the angiography study, and immediately after the echocardiography developed, we moved to color Doppler, allowing us to assess and quantify the mitral regurgitation, the aortic regurgitation. Then the technology developed also, and we get strain and the tissue Doppler imaging, and the machine became something as a smartphone connected with the proof, which is not the future. Your generation has this ability and this possibility to work nowadays with this kind of machine. So the future is now, and your generation has to be able to use digital echocardiography, and this allows us today to share the experience using telelearning sessions, and to understand better your and our job. Echocardiography is not anymore a magnetic tape registration or thermal paper registration. Echocardiography becoming digital allow us to share the experience of the surgeons, confronting that experience with the images from the intraoperative field. So my first message is that the only tool to repair the mitral valve is the echocardiography. Please consider the echocardiographer as a virtual eye of the surgeon, allowing with this method to the surgeon to see and to understand which kind of disease he has to operate. As Horia showed us, Dr. Muresian showed us, please ask to your cardiologist to be precise on these 8 elements of the mitral valve. Please consider the mitral valve as a 6-cusp valve with 2 pair of scallops, A1 and P1, A2 and P2, and A3, P3. Today is not anymore acceptable, possible to do the surgical planing, opening the left atrium and trying to, with the hooks, to understand. It's enough to have a very good echocardiographer and to have a team to get a very high result with 100% of feasibility of repair. This is a Barlow disease, a very huge and giant transformation of the valve, and probably some of you will ask me how many surgeons will be able to repair such a valve. I don't know, depends on the experience of the center and the echocardiographer, but the strategy of mitral repair was stated in 1971, 1970s by the father of mitral repair, who is Professor Carpentier, and he settled that it's necessary to resect the prolapsing zone, to rebuild, to reconstruct the posterior leaflet, and then to reconstruct the annulus, and nowadays to gain the coaptation using the Gore-Tex corde. To obtain, to have such a result, the surgeon must know some very important information, and one of this is where is the lesion, and I will explain you immediately after how to have this collaboration with the virtual reality from the echocardiography with the reality in the operating field. And also it's very important to know if we have to repair a simple mitral insufficiency, what that means, 1 leaflet disease or 2 leaflet disease. It's very important to know how is the extension, how large is this the prolapsing zone, because if the surgeon has to do a very large excision, the amount of tissue available will be less than necessary, so we will have problem, and I will show you some example later on. Also, the echocardiographer must to assess the dimension of the left ventricular cavity and also the dilation of the annulus, and to assess the risk of this complication, systolic anterior motion, that I will show you a case at the end of my presentation. So As regard the first aspect, the etiology and the anatomy, I want to remember you that we have more types of degenerative mitral regurgitation when we speak about mitral valve degenerative disease. And this is a very nice article of Professor Adams showing that it's not the same to operate a patient with fibroelastic deficiency where the thin chordae the thin leaflets may be a problem for the surgeon, and that's why the role of the echocardiographer is to transfer. Keep in mind that you have to operate a fibroelastic deficiency, and maybe not all the surgeon will be able to repair such a valve. The second aspect, as I told you, is the dialogue between the surgeon, the brain of the surgeon, which is an anatomical brain. If he has a lesion on the anterior leaflet A1 scallop, he will see the lesion on the left part of his visual field of operation. But due to the virtuality of due to the convention in echocardiography, the cardiologist and also the surgeon will find this lesion on the screen of the machine on the right part, upper part, and doing transesophageal. This is a reversion of the image, so he will find the image on the right part of the screen but down. So this creates confusion initially between these two persons using a real brain, anatomical brain of the surgeon and a virtual brain of the cardiologist. That's why the cardiologist must take the atlas and study the anatomy, and discovering that we have A1, P1, A2, P2, A3, P3 scallops. But if you study the anatomy of the mitral from the atlas, you cannot understand why this is anterolateral. And where is posteromedial in the atlas. So you have to go in the operating theater and to understand that you have to rotate this image. And in this moment, it's very easy to understand that if I want to get maximum of information by the way of these scallops, I have to stay perpendicular with my proof. So if I will use transesophageal, I have to stay at 0 degree. And if I want to see this part, I have to stay at 90 degree. And this is an example of 0 degree assessing A1, P1 scallops of the flexion of the proof. As you can see, there is prolapse of the anterior and posterior leaflets at this level. And if I want to see so assess the A3P3, I will move to 90 degree of the proof, cutting all the valve between the two commissures, and this is a bicommissural image. And if I want to assess in transesophageal echocardiography A2P2 scallops, I have to move more to rotate the proof around the 120, 130 degree, and to see very well A2P2 scallops. In this case, it's a prolapse, flare rupture, and severe mitral regurgitation. Using this two-dimensional echocardiographic assessment, transesophageal assessment, you have to complete the assessment of the valve moving in transgastric view to see where is the region of coaptation and where is the mitral insufficiency. Of course, if you have 3D echocardiography as in the last period of time, at a glance, the surgeon and the cardiologist will understand where is the lesion. But nowadays, not all the people has 3D transesophageal echocardiography. And in the everyday practice, we have to manage this patient and to decide and to have to decide if the patient has to repair the mitral valve using transthoracic echocardiography. And I think that you must keep in consideration that you have to use a mental 3D approach. What I want to tell you, in the same image, if I want to assess, by the way, the A2P2 scallops on the mitral valve, it's enough to move the parasternal long axis view, and will be possible to assess, to check by transthoracic echocardiography the scallop A2P2. And if I want to see, by the way, A3P3 scallops, I have to move not in parasternal but in apical view to orientate the proof down, and I will see A3P3 scallops. And also, if I want to see A1P1 scallop from apical view, I have to orientate the proof through my shoulder, and it will be possible in most of the case to assess A1, P1 scallops, and then to combine and to verify in short axis view, parasternal short axis view, if this information is a true information. Sometimes, if you have 3D, it's possible to reconstruct the mitral valve in 3D approach, transthoracic approach, but usually the quality of image is not so good. But this is a very important information because allow us to understand how is the extension of the prolapsing zone, which is very important for the surgeon, and I will show you immediately after. There is some, we have some very, very important messages coming from the anatomy, from the anatomy, the geometry, and the function of the mitral valve. And in this nice picture from Horia Muresian, I will I want only to underline the strut chordae, which I seen never ruptured in the degenerative mitral regurgitation, but on the contrary, the posterior leaflet, it's the region which 2/3 of patients will get a rupture or prolapse of the posterior mitral leaflet. And we have to, if we want to repair the valve, we have to understand why it's happened, something like this. And please compare the anterior, comparing a confrontation between the anterior and posterior leaflet. As you can observe, the posterior leaflet is shorter respect of the anterior. And you can imagine that it's easier to break longer stick comparing with a shorter stick. And despite of this smaller dimension of the posterior leaflet, we know from the practice that the posterior leaflet is 2/3 of patients with prolapse and rupture. So why it's happening something like this? But look also at the chordae. The chordae of the posterior leaflet are shorter comparing with the chordae of the anterior leaflet, which are longer. And not only, look at the posterior leaflet. As Dr. Muresian showed us, we have neural chordae to reinforce, to stabilize the posterior leaflet, but despite of this, the posterior is the rupturing leaflet. So why this is happening in the real life? And we have to remember that the physiology, the vectorial forces inside of the left ventricular cavity are very different for the anterior and for the posterior leaflet. We have to consider that the anterior leaflet is a velocity leaflet because the blood is sliding on the anterior leaflet. As you can see, there is a sharp angle from the vectorial point of view of the blood pushing into the anterior leaflet, and at contrary, on the posterior leaflet, the blood is pushing in at 90 degrees. We have to consider that why that the posterior leaflet is rupturing because the blood used the posterior leaflet as a true trampoline, pushing all the forces, systolic forces on the posterior leaflet, and that why maybe he will not resist. And here in practically, if the patient has degenerative mitral regurgitation, he will get rupture or prolapse. It's very important to judge and to understand what's happened with the geometry, because sometimes due to very high elasticity, sometimes the chordae of this patient in the anterior leaflet will become longer and longer, and the angle of the anterior leaflet may change. And if you have an angle like this, the anterior leaflet is not anymore a velocity leaflet. And as you can see later on, this became a pressure leaflet. So please consider that transesophageal echocardiography allows us to see better the heart because we have 3 millimeters between the groove and the mitral valve. Also, the 3D gives us the possibility to see the valve in a surgeon line like anatomical view. Please consider that 3D echocardiography, if you have it, will allow us to instantaneously see the culprit lesion and also to assess the extension of this lesion, which is very important for the surgical technique, as I told you before. It's not easy to understand in two-dimensional echocardiography. from an image like this, it's really difficult to assess how large is this portion, this prolapsing zone. And this is very important for the surgeon, because the strategy of the surgery depends on the extension of the prolapsing zone. And it's really difficult to assess in two-dimensional transthoracic echocardiography how large is the prolapsing zone. Maybe if you have 3D transthoracic echocardiography, you will be able to see for sure. Will be easier to understand how large is the extension, and the surgeon, yes, has to resect, but in the same time he has to respect to left enough tissue on the A1 and on P1 and P2 scallops. Otherwise, as you can see in this image, the posterior leaflet will remain a fixed, immobile leaflet. And understanding this aspect, our team in the last period of time moved from large quadrangular resection to small triangular resection, and maybe the surgeon will discuss this aspect with us, allowing us to obtain an ideal mitral regurgitation with mobility of the posterior leaflet, presence of triangle of coaptation and long coaptation. The question is, if we have 3D, it's enough to do a good mitral valve repair? It somehow seems to be like this, because with 3D echocardiography, we may assess the mechanism of mitral regurgitation, the quantification, to assess the extension, and somehow the geometry. And in the last 25 years, there are machines, if we have money enough to buy the machine and to rebuild in 30 minutes the geometry of mitral valve, we can arrive to understand the mitral geometry and the concept of triangular coaptation, which is a very important concept in the mitral valve, because normally if the balance, the amount of elastic and the collagen tissues are a normal one, the coaptation point of the normal valve is situated inside of the left ventricular cavity, which is not the case in patients with myxomatous mitral valve, Barlow disease, or fibroelastic deficiency, where this geometry, this triangle of coaptation disappear or is deformated. And in the everyday practice, we don't use this kind of, which is very useful, but you need time to reconstruct the valve, to understand the anatomy and first of all, the geometry. That's why I will suggest you to use this virtual triangle of coaptation, and to consider the base of this triangle to be the septomarginal diameter of the mitral valve. In the everyday practice, the intercommissural diameter, lateral diameter, is not so important. The most important diameter is the anterolateral one, or septomarginal diameter, because the mitral valve is a valve working in an antero-posterior diameter. So very, very important measurement for the everyday practice. That also you have to consider the coaptation 8 of this triangle, which reflects the elasticity of the mitral valve. When this coaptation 8 is smaller, the elasticity of the valve is higher. And also, please remember that the tip of this triangle, we have to have at least 6 millimeters of coaptation to consider that this is a normal mitral valve. And this is an image from the intraoperative echocardiography. This is bicommissural view. As you can see, we can discuss which scallop are involved, but if we have the concept, the mental concept inside of the triangle of coaptation, we immediately will observe that this patient has not anymore a triangle of coaptation due to the elasticity, due to the prolapse. And this is the surgery and the post-operative result. As you can see, there is a ring over there, there is a good coaptation, there is no mitral regurgitation, but please observe, keep into consideration that the surgeon rebuild a triangle of coaptation, not by chance, but because this is a very important aspect. And allow me to stress another one, the importance of judgment of the valve using this concept. Please consider the point of coaptation here or here to be expression of the right balance between the collagen and the elastic fibers. We observe in patients with prolapsing mitral valve, when we perform the echocardiography in the relatives of this patient, sometimes the point of coaptation is not here, but is not here to be a true prolapse, that we may have the coaptation point in front, immediately in front of the virtual line of the mitral plane, which is an abnormal condition. This is a elongated mitral cord, which has importance in the everyday practice, like in this patient, 25 years old, Marfan patient with 52 millimeters of ascending, 53 of the ascending aorta. So we have to operate the patient for the aorta. But what about the mitral? The coaptation point is nearby to the mitral plane, and this is an elastic disease, hyperelastic disease. Look at the anterior leaflet. It's not anymore a velocity leaflet. This is a pressure lifter. So it's only a problem of time when this patient will get mitral prolapse. That's why we perform Tyrone David, saving the aortic valve, and we put a ring to stabilize the mitral. Otherwise, this point of coaptation in this kind of patient, slowly we slide inside of the left atrium, and the patient will become patient with mitral prolapse, and we start to discuss what about the symptoms, what about the atrial fibrillation, the quantification. So my message is, in patient with degenerative mitral regurgitation, please consider that the mitral function depends very, very much of the geometry of the valve. And if we not respect this concept, it's only a problem of time when a patient with a mitral like this will get rupture and will become a patient with flared mitral valve, and maybe not all the surgeon will be able to repair. So the last message regarding the geometry is, when you repair, when you member of the heart team have to repair a mitral valve, please remember the geometry and rebuild also the geometry of the mitral regurgitation, which explain again the important role of the cardiologist in the heart team. We use in our practice 2D echocardiographic assessment, using a very standardized approach in assessing the mitral valve in transthoracic echocardiography, to avoid, it's not ever necessary to perform transesophageal echocardiography. If you have a good machine and a good standardized algorithm, approximately 80% of the lesion can be identified by transthoracic echocardiography, but you must use this scheme, this algorithm, dividing the mitral valve in 8 anatomical elements, and you have to specify, you cardiologist or you surgeon must ask to the cardiologist which kind of lesion I have for each pair of scallops. Also, it's possible to calculate the prolapsing score, and it's not the same thing if I have to operate 1 by 8 elements scallops and commissure, or patient with 8 by 8 diseased element. So nowadays, it's possible to have a surgical planning, echocardiographic surgical planning before opening of the left atrium, and maybe the surgeon will decide to do maybe sternotomy and not robotic surgery, or maybe not many invasive surgery if the case is very, very complex. The last thing that I want to share with you, it's the risk of sum and the relationship with the mitral geometry. In front of the patient like this, the surgeon must know which is the risk of sum. Systolic anterior motion is a complication when this tract, left ventricular outflow tract, is too tight, the velocity of the blood is too high, and we may have this kind of complication, which is eversion of the anterior leaflet, mitral insufficiency. This is a complication with this incidence in the repair surgery, but sometimes this is a very serious complication. We have seen patients with more than 100 millimeters of mercurium in the left ventricular outflow tract with severe mitral regurgitation, severe hypertension, and impossibility to wean the patient from the cardiopulmonary bypass, and maybe the surgeon will decide to put a prosthesis. How to judge this patient? How to discover this patient? Please remember that atrioventricular orifice, as Horia Muresian show us, is occupied 2/3 by the anterior leaflet and only 1/3 by the posterior. Due to elastic tissue and due to the pushing of the posterior leaflet, sometimes the posterior leaflet became higher. And when this ratio between anterior leaflet divided by 2 to the posterior is less than 1/3, 1/2, 1/1, the risk of systolic anterior motion is high or very high. And also in patients with very narrow left ventricular outflow tract that can be in patient with left ventricular important septal hypertrophy or small heart due to the high velocity or high kinetic energy of the blood in left ventricular outflow tract. The kinetic energy will produce absorption of the anterior leaflet and the mitral insufficiency. Using this criteria in the last 6, 7, 10 years, I never see some in Bucharest and in Novara. And with this last aspect of the echocardiographic algorithm in surgical clinic, I will finish my presentation. Please remember, as the surgeons and also the echocardiographers, we are looking in the mitral valve to the regurgitation, to other things, but the most important thing is the coaptation of the valve. So we must assess the coaptation for all X3 pair of scallops to consider normal before and after surgery to be at least of 6 millimeters, and to describe, as in this case, loss of coaptation, which is very important to be repaired, to be reconstructed by the surgeon. And also, please remember that when we have dilation of the annulus, we must have ever reduced coaptation. And please remember that the main diameter that you must measure is the septomarginal diameter. And also you can help the surgeon using measuring the dimension of the anterior leaflet, because the mitral valve, it's a valve working in an anterior posterior diameter. So also the surgeon is measuring the anterior leaflet to decide which kind of leaflet. And again, this is show us the role of echocardiographer in the heart team. My final consideration regards the triangle of coaptation, and please consider this virtual tool as a tool able to analyze the mitral valve geometry before and after surgery. This triangle of coaptation, using this structured algorithm and the triangle of coaptation in our practice, the mitral valve repair is feasible with a very high percentage, nearby 100% of patients using Goretex corde and annuloplasty, and ever necessary to do transesophageal to assess if the patient needs or to stabilize, to choose the surgical planning. If you have a very structured, standardized algorithm of examination like this one, you can get a very, very good dialogue with the surgeon, and you can get a very good result. Thank you. Please excuse me for so long presentation and maybe for my English.
Thank you, Dr. Cerin. It was a great presentation. We have also some questions for you. The first is the exercise echocardiography useful in the preoperative analysis?
Yes, of course. First of all, in patients with moderate mitral regurgitation without symptoms, the stress echocardiography show us if the patient changed the degree of mitral regurgitation. It's a very interesting tool. Stress, I mean physical stress, but also maybe much more in a patient with ischemic mitral regurgitation, dipyridamole echocardiography, or dipyridamole. Anyway, pharmacological echocardiography can help. Usually nowadays, the surgery, and maybe Marco Diena and also Theodor Cebotaru will discuss this aspect, is indicated in symptomatic patients. So if I have the patient with some mitral regurgitation, which seems to be moderate, some seem more than moderate, with some degree of dilation of the left atrium and the left ventricle, but the patient has no symptoms, the stress echocardiography is very useful.
Thank you for your answer. The next question is...
I would like to comment afterwards, after the questions, okay.
Okay. The next question is, what are the key aspects that you are looking for in the intraoperative echocardiography after finishing the mitral valve repair so that you can be sure everything is set up and you can close the patient?
The coaptation is the most important thing. If the surgeon understands the mechanism of mitral regurgitation, I think Theodor Cebotaru, Horia Muresian, and Marco Diena will confirm me that the basic thing is to rebuild the coaptation. The second aspect, if possible, to rebuild the geometry, because if I will push anterior to the posterior, they are very thin valve, but closing inside of the left ventricular, they push each. But if I will close in the left atrium, the future of this repair will not so good. So the coaptation is the basic thing. The second aspect is the triangle. If you have good coaptation, doesn't matter if your color Doppler is not functioning anymore and your machine has not, because you are sure that you have a very good mitral repair without mitral regurgitation. But of course, if the coaptation sometimes is not perfect, you have to assess the amount of residual mitral regurgitation.
Okay, thank you. And what I think is the last question for now. How much is the accuracy to find lesions with 2D echography?
I show you 80% with 2D transthoracic echocardiography. If you have a second harmonic machine, and first of all, if you have a very standardized way of assessing the mitral valve in 2D using a mental 3D echocardiography, which is in your brain.
Yes, I'd like to comment something in the wake of your presentation that is very important now, because we know that surgeons would like to operate always and as much as possible, but nowadays surgeons have become more careful, and they know more about the natural evolution of diseases generally, and especially in mitral valve disease. We know the natural evolution, we know the resources of surgery, of medication, and conservative treatment, and so on. But with the advent of the elements you have stressed in your and underscored in your presentation, it is very important to anticipate some of the lesions and their evolutions, and sometimes to operate before some symptoms or some complications of the disease will appear. And this is also a very important direction for the future, for determining which patients should be operated even first before the symptoms, clear symptoms will appear. And this is very important in the echographic assessment of the mitral valvular complex. Thank you.
Thank you so much. We have another question, but I think its answer is in the next presentation. The question is better to repair the valve or to change the valve in the insufficiency? And what about transaortic valve emplacement? Is this a good method to treat mitral insufficiency? I think we will listen out to Dr. Cebotaru, and we'll find the answer in the next presentation. Is that okay?
Of course.
Thank you. Dr. Cebotaru?
Yes, I'm here. I will start now. Okay, I will speak now about robotic mitral valve surgery. It's our current status. Our current status, what it means? It means that we start robotic surgery only 2 years ago. It's a new procedure. For you, it's better to start to understand you what means minimally invasive, because normal surgery or classical cardiac surgery means medium sternotomy. Medium sternotomy means a fracture. Sternum is cut in half in the medial part, and it needs recovery. The recovery is at least 1 month, so it's a little bit long. Minimally invasive surgery means doing this surgery. Inside, it's a normal procedure, but without cutting the sternum. It's between the ribs, between the right side of the chest. We can perform aortic, mitral, and the tricuspid valve, or all three together. In the left side, between the ribs, we can perform KBGs, or the bypasses, revascularization of the heart. I started about, let's say, 20 years ago, minimally invasive surgery, but serious. More than 80% of my procedure are now minimally invasive surgery, starting from 8 years ago. The next step in minimally invasive surgery, in my mind, was using the robot. I was trying to replace, I'm trying to replace in the future the minimally invasive classic surgery, the minimally invasive with robot surgery. So I will speak now the first steps of the robotic surgery. The robotic surgery has a lot of advantages, but has also disadvantages. In this part of the starting surgery, what I feel now is only the disadvantages. Minimally invasive surgery without robot means incision small incision, about 10 centimeters. You are doing all yourself. The surgeon is the main part of the procedure. You can do the procedure without another surgeon on the table. You can do the procedure with a nurse. In robotic surgery, this is not the situation. The surgeon is not even at the table of the surgical table. It's some meters away, or in another room, or it happens some years ago in another country. The surgeon was in France and the patient was on a table in New York. So this procedure means that you need to have another surgeon on the table. He needs to be trained, very good trained. So the procedure will be as short and with the same benefits or more benefits than the non-robotic minimally invasive surgery. The advantages of the robot is smaller incision, as is written here, no retractor, no pain. It's increased dexterity for surgeon. It has 6 degrees of freedom compared to 4 in endoscopical surgery. It's tremor-free movements, ambidexterity, excellent 3D images, and greater zoom. Zoom, it's 28, I think. It's a big zoom, and improved cosmetics. Disadvantages, as I said before, it needs a long learning curve. It's a team-related surgery, depends on the skill of the whole team, not only on the main surgeon. And unfortunately, that means a longer time of ischemia for the first 20 cases or even more. In cardiac surgery, I think the time of ischemia is crucial. If you manage to do the intervention in a short time, it will benefit more after. And also the robot costs more than minimally invasive non-robotic surgery. Why I start with robotic surgery? Why? Because it's a step forward in surgery. Now it's a struggle to do the procedure, to have advantages toward non-robotic minimally invasive surgery. And I left this page blank because I'm now in doubt about the advantages of the robotic surgery. Maybe in the future, when also the team will be okay and the procedure will be shorter, and I will be able to replace also other procedure, not only the mitral valve repair. With the robotic surgery, it will be a step forward in surgery. In current status, what are we doing in robotic surgery? Only simple mitral valve repair and ASD, atrial septal defect, closure of the atrial septal defect. We start the first case with balloon occlusion. What this means? Balloon occlusion, that means that we clamp the aorta and we use the cardioplegia with a device. It's a balloon put through the right femoral artery. And that means that we don't need inside the thorax, no clamp and no additional cannulation. Now we are using the external clamp grow flexible. That means that the incision, it's a little bit longer than normal robotic surgery. We put and we use the clamp, and also we administrate the cardioplegia direct in the ascending aorta. The cardioplegia is the Nidor type, and we use this mixed technique. That the incision is a little bit longer, and we use clamp. That means mixed technique. What means the robot? What it does different from the minimal invasive surgery? In minimal invasive surgery, you have an incision, let's say 10 centimeters, and you are using instruments and you are using your hands. In robotic surgery, you put 4 holes, small holes are here. A small incision is the working port. The working port is the main access for the second surgeon who's helping you. Then are 2 ports for the instruments. 1 port is from camera and 1 port is for retractor. The patient is with the right elbow elevated, and the surgeon is not here. It's in the corner of the operating room. I stay on station work. I'm not even wash my hands. I'm normal. I use my hands. And the second surgeon, that one who helps me, is actually on the operating table. And now, because we're live in the box, I will present you an operation on mitral valve repair. And for answering the previous question, if it's better to repair or to replace, it's better to repair the valve. When you can, when it's feasible, when it's doable, you need to repair. It's not good. You need to repair the valve, because the complication at 20 years on a valve repair, it's about 4-5%. On a prosthetic valve, metallic or mechanical or biological one, is about 90%. So it's better to repair. Also, if you repair the valve, you can obtain a normal valve who don't need medication. So the patient will not be connected to frustrating everyday medication. Okay, I will start now the video. First of all, we go in the space. This is the space between the right and the left atrium, Zondergaard space. We enter in the left atrium. In the right hand, I will put pause now, a little, oh, sorry. Okay. So, in the right hand, I have a scissor, but if you see here, it's a monopolar. It's a scissor who's also doing coagulation. And in the left hand, I have forceps, a Risano forceps. So now we enter in the left atrium. Next step will be the putting the retractor. The retractor, you can see it above. It's now only retract part of the atrium. It will go inside, more inside the retractor. You can see now a part of the mitral valve. This is the mitral valve. In robotic surgery, you need to cut the left atrium more than in minimally invasive, because you need to have a very good surgical view, surgical field, adjust everything to see very, very good the mitral valve. So it needs some points of retraction of the left atrium walls. Another one. With this one, we placate the left atrium, but we close also the left auricular. So it will have two things. One is a good field, and second, the left auricular will be closed. It's okay to close the auricular, because the main place to appear the thrombus . So I'm using what you see, the metallical things, the left and the right instruments, and the second surgeon, that one who's on the table, retract the needle when it needs, and also put tension in the wire, in the stitch. So when I started robotic surgery, I was doing this type of suture. Now I don't use it anymore. I put only some stitches to see more the mitral valve. And why I'm not doing this stitch? Because I'm afraid of the circumflex artery. It's very close. So this is the assessment of the mitral valve. And this one was congenital disease, also with
left.
With a prolapse of the posterior valve. We have the cleft on an anterior, and something like a cleft on the posterior. So I cut this fibrotic and prolapsing part of the posterior valve. After this, it's only a suture of the posterior. A straightforward double suture of the posterior part. Also noting the wires, the stitches is doing what with the robotic arms, with the instruments, not with the hands. So if you see that the second surgeon is the one who's pulling out the stitch. And he is doing the knotting at the end of the double stitch. Now it will be assessed again. Because it's a congenital lesion here, the proportions are okay, more on anterior than on posterior. But the annulus, if you see, the annulus has piriform shape. Here, annulus seems to be reversed. So I put this annulus, this ring, reversed, not in a normal position. And I let the cleft like this on anterior. Here it's the cleft. I left it like this because it has a lot of good chordae and was a normal functioning valve. I didn't close the cleft. To gain more time in putting this ring, the artificial ring, we use cornot. Cornot means this mechanical suture without need to be knotting from the second surgeon from outside.
What is the risk, Theo, regarding the implantation of the ring? Do you need particular information to avoid some risky problem, or it's a routine procedure?
It's a routine procedure. It's a routine procedure to put the ring. So when you start always on the anterior commissure, and it's going on the posterior wall toward the anterior, and then you start again from the anterior commissure on the anterior leaflet toward the posterior commissure. So it's a routine to put the ring, but you need to know that with every step you can change the normal implantation of the ring. Every step needs to be adjusted in mind where it will be on the ring. The risk is to put more stitches on the left side and the less stitches on the right side at the end.
What about the circumflex artery?
Well, on the circumflex artery, if you put the stitches normal only on the ring, on the annulus, on the mitral annulus, it's no risk. So when we start the procedure, because the proctor, the one who helped us and who teach us to do the procedure, was doing that stitch that you see before, the double placation of the left atrium wall with closure of the left appendix. This was in his mind to help the view but I didn't like. I was doing like this for the first operation because he asked me to do like this. But after I was alone, I was independent, I didn't do it again because I'm very afraid of the circumflex. The circumflex is going exactly in that part where this double stitch was doing before.
Sometimes in echocardiography, we may show the short distance between the annulus and the less than 3 millimeters circumflex.
Yes.
It's very important to
it's very important.
keep in mind.
Yes.
And also the angio, probably in young people, I don't know if you use standard angiography or only angio CT.
No. After, let's say, till 40 years, we don't use, only eventually angio CT, but not angiography. After 40 years, we do on all patient angiography. Okay, so for the future, this is the first step. We need to convert this to smaller incisions, 3 centimeters, with using the intraclude. Intraclude is that balloon that I spoke before. It's occluded aorta, ascending aorta, and administrating also the quadriplegia. Now it's not used in Romania because they had Edwards had some problems with its balloon, and maybe the next year will be another type, another improvement of the balloon, so it will be sold also in Romania. The second step is more to do more complex cases of mitral repair and to move forward to other valves, to the mitral valve replacement, to doing the aorta, other procedures. Okay, thank you.
Thank you very much, Theo. Can you hear me?
Yes.
Yeah, very nice operation. Let me know, is still you're a very skilled surgeon, is still not easy to perform a robotic mitral valve repair in terms of technical aspect and the skill. And for this operation, how long is cross clamping time after the learning curve? So after the
in the first case the crossing climb was, let's say, more than 2 hours.
Of course, but later on, of course. But
now it's longer. It's also longer than in minimally invasive, not robotic surgery, because in robotic surgery it's, let's say, maximum 1 hour. With robot, it's 1 hour and a half, 1 hour and 45 minutes. It's longer. Okay. Still longer. It's still longer. It's still not an advantage. Robotic surgery.
Thank you, Dr. Cebotaru, and hello, Dr. Diena. We have now some questions from the public, if you want to answer. The first question is valve repair or valve replacement. How is the decision made?
When the valve is not, well, let's say, first of all, is the cardiologist who's saying this valve must be repaired. After this, you are looking at the valve. If the valve is not with calcium, the annulus is not fibrotic, the leaflets, anterior and the posterior leaflets, are okay in terms of material, and also the subvalvular apparatus is normal, you do a repair. It has a lot of, if the valve has a lot of calcium, the leaflets are modified, are fibrotic, retracted, I'm not doing repair. I'm replacing it.
Okay, thank you. The next question is, can the patient develop any infection because of that ring and the mechanical knot?
No, it's not different, let's say, from a prosthetic valve, artificial valve, or for normal surgery. endocarditis can appear on the valve who has a ring or a repaired valve in the same percentage like in normal operation. So it can develop an infection, but not because of operation, because some infection appeared after the intervention, not on the first month, let's say.
Okay, and a mechanical valve or tissue valve, which is the preferred option?
Depending on the age of the patient. Younger patient need to have a mechanical valve, and because the tissue valve, let's say, even if with this new appeared tissue valve can be function for, let's say, 15 years, more 20 years, but after also that tissue valve need replacement.
Okay, thank you for your answer. The next question is, what are the most common incidents that can occur in the robotic mitral valve repair?
It can be a dramatical incident. It not happened, but I heard of this. The robotic arms has a great power. You cannot imagine the power you have in the mechanical arms. When you use this kind of procedure, you have your fingers towards putting some rings, and you don't feel any feedback on what you are doing. So if you are pushing the arm toward a tissue, you don't feel the feedback. You have only the 3D images who's telling what are you doing. With robotic arm, if you are not, let's say, sorry?
If you are skilled enough.
If you are not skilled enough, or if you are not, yes, if you are not skilled enough, with an instrument, it happens to pass through the patient and to the table with instant death. So there are a lot of incidents that can appear with robotic surgery. Okay,
I see. The next question is, how much time do you have for a surgery like this in order how much time do you have for a surgery like this in order to avoid high damages because of the ischemia?
Yes, it's a very good question. Now, in non-robotic surgery, the ischemic time is less than 1 hour. In robotic surgery, I start with almost 3 hours of ischemia. This is very, very bad, and you may have very big problems with this. But it's normal with a learning curve that needs to be adjusted not by the main surgeon but also the second surgeon. After you pass this, it needs to be like in a non-robotic minimally invasive, so let's say less than 1 hour. When I decide to do this robotic and to start the program with the robot, I watch a surgeon in Holland, and he has in that time, he has times, let's say, less than 1 hour of ischemia, and I think it's doable. You can start the robot, have patient with the team to gain the main time, let's say less than 1 hour of ischemic time.
Thank you. And the last question, I think, how difficult is it to go through the learning curve in robotic heart surgery?
Well, it's harder than any surgery. You need to have some hours of simulation. You have a simulation machine. The simulation has a program with very, very long steps and many steps to do. So when you start to do actually the surgery, you need to have at least, let's say, 500 hours of simulation. And after this, you need to go to train to animals. And after this, you need to have a proctor who help you in the operating room, who's doing himself a lot of time of the procedure. After this, you need to start with very, very easy cases to avoid the ischemia time. And it needs time. It's the most the difficult, let's say, surgery to gain.
Okay. Thank you so much, Doctor, for your presentation. It was amazing. And now I want to welcome Dr. Diena. It's an honor to have you here.
My pleasure. Thank you.
Thank you so much. You may start your presentation.
Yeah, I have to share my screen, correct? Good morning, everybody from Milano, Italy. It is really a pleasure to be here with you. And I just have assisted to a very high level, outstanding presentation. And we are quite often to some meeting. Can you see maybe in a few seconds my slides? Can you see my slides?
Not yet.
No.
I share the screen. I try. Can you see? Anyway.
Not yet.
No.
No.
Stop presentation. Maybe I have to share the screen. Wait a minute. Because I tried to share the screen. Maybe you can condivide lo schermo. Condividi. Okay. Now I think you're going to see. Okay, now yes. I open the presentation. So yeah, I was saying is a really pleasure. I open the presentation is going on. Because I work a lot of time with Dr. Cerin in Novara, in San Gaudenzio, and I have to move. I moved from. I can open this. I don't know why. Sorry for that.
No problem.
Yes, and all the result we have had is thanks to his own. I go anyway. I have to go back to the presentation. Sorry for that. This one. Just before showing my video, I would like to say that the real advantage of mitral repair is for the audience. I know that the audience is from different centers in Europe. Is it correct?
Yes, it is.
Yes. How many countries are connected to us? How many people? Do we know?
There are a lot of countries and a lot of continents, I can say.
Really? Wonderful.
Yes.
I know that
yes,
something as 50 universities from all over the world.
Mm-hmm. And here's my presentation. Can you see now?
Yes. We can,
wonderful.
We can see it. Yes.
So I want to share to the students and the young surgeon this presentation just before the video, because we had last year in Mitral Conclave in New York, we presented towards 100% mitral valve repair in sternotomy, the experience until 2010, and minithoracotomy in our center from 2010 until last year. The very important thing is that the mitral valve repair is the operation of choice in degenerative disease. You can see here is the survival in patient in two group of patients compared by Gillinov, the survival in green patient that receive a repair compared to patient receiving the mitral valve replacement. And you see this for student and young surgeon that already the mortality in the hospital mortality is less important in mitral valve repair. So already at the time of the operation, mitral valve repair is better. And also, of course, as said Dr. Cebotaru, Dr. Cerin, the event-free survival is much better in mitral valve repair because they don't need anticoagulation, they don't have prosthesis, and so the risk of endocarditis is very low. But the problem is that the repair rate in Europe and the States is still quite low, about 62–64%. And the last report is 67% in degenerative disease, and except in dedicated center where they reach 95%. So the problem is that the surgeon should be very well educated to go to a mitral valve repair than to a replacement for these important reasons. So this experience we share with Dr. Cerin and the other colleague in Novara in San Gaudencio Clinic. That was more than 800 patients with severe mitral regurgitation, and I want to focus the attention to the surgeon that the indication, the guidelines say that is indicated the mitral valve surgery in degenerative disease if the regurgitation is severe, but if the surgeon repair the valve. So you must go to learn how to repair every degenerative valve and you are allowed to operate also asymptomatic patients. So the first half until 2010 were operating through sternotomy. Half of the patients were operated through minithoracotomy in the last 10 years. And this was already presented by Dr. Cerin. Here we were in Timișoara. This very nice experience in different area where we shared our experience together with the Romanian surgeon that are very, very good skilled surgeons. And I go very quickly because maybe we are late. I suppose we are late. The technical aspect of the coaptation was already mentioned by Dr. Cerin. This typical flail posterior leaflet. The surgical technique, as we have learned by Carpentier in the last 30 years, is very simple, but the important thing is that in this experience we had 99% of repair in sternotomy and until now 100% repair in minithoracotomy. So this thanks to the very effective and precise echocardiography in transesophageal echo in the operating room. And the repair rate is more than 99% in this group. And this is very important, but it's extremely important to have very good echographists in the operating room. So moving from the standard technique of quadrangular resection that gives it most frequently a fixed posterior leaflet, as you can see here, it was quite a good repair. And now we move in many other centers to be more respected and resect. So to do triangular resection, to keep a certain mobility of the posterior leaflet, and if it's possible to have the ideal operation, that means to have a complete mobilization of the posterior leaflet, preserving most tissue. So this is the ideal repair in our hands, and that means to have a very good coaptation length, more than 7 millimeters, a triangular coaptation, and mobility of both leaflets. But then I move quite quickly to the video. This is, I hope it will work. Can you see the video?
Yes.
Okay, so this is a 5 or 6 centimeter incision in the third or fourth intercostal space, right? And this is the endoscope. We always use endoscope. In the last months, we received also a 3D endoscope. This is very helpful for the operation and to allow all the team to follow the operation. And maybe it's better that I move to the complete endoscopic view. That is this one. So we have the endoscope here, and the surgeon through this incision that followed by all the team in the operating room. We already know when we cross-clamp the aorta what we have to do on this valve. And in this case, we have quite a valve disease with a B-leaflet prolapse with extensive flail of posterior leaflet. In this case, we did quite a good resection, quite a wide resection, but usually we do small resection as far as possible. Then to keep easily operate the operation, we do a running suture to restore the continuity of the posterior leaflet with a 4050 Gore-Tex artificial line stitch to go up and down, and a 50 Gore-Tex with a small plate jet, as you can see in here, to put the artificial cord on the arterial leaflet. This is the tip of papillary muscle, and this is the free edge of the anterior leaflet. This is A2 to restore the coaptation of A2. This was a patient with bileaflet prolapse, and with this one or more artificial cord on the arterial leaflet, we can restore the coaptation on both leaflets. And for us, it's quite a quick operation to put a cord with endoscopic instrument, because we have a long experience of artificial cord, and I think this is the quickest way to repair a valve in minimal invasive surgery. Since a few years ago, we use routinely the direct view with the loop, and more recently we use with the 3D endoscope. We prefer to use, we can repair those valves, totally endoscopic with the 3D endoscope. We always use a complete ring. Of course, we never undersize the ring in degenerative disease to avoid SAM. And every time that you have a large posterior leaflet, we do resection. And if it's not enough, we put artificial cord on posterior leaflet. A very important issue is that is the smile, but the coaptation should stay behind the midline of the ring. And this is a quite good system to assess at the end of operation, before unclamping the aorta, how to not to have a systolic anterior motion. So this again, the previous technique. Now we don't use the retractor, only the soft tissue retractor, because the 3D echo allows us to do a totally endoscopic repair. You see sternotomy in compensated disease like this was 58 minutes cross clamping, a little longer minithoracotomy. Now this shorter clamp. But of course, the comparison is that sternotomy, the minithoracotomy, have a less bleeding, a less need of blood transfusion, less chest pain in this chest pain score. And so it's really minimally invasive. It's not only cosmetic. This is very important. The hospital mortality is very low in both groups. There is no difference in terms of p-value, and total mortality is less than 1%. Though the conventional sternotomy was only at the beginning of this surgery, very, very low. And you see that with a good echo, a second cross-clamp time to adjust the repair is about 2% of the cases. So we should know when you cross-clamp the aorta exactly what you have to do on the valve before in the working heart and not in the heavy heart. So we never have to replace a valve after repair in the same hospitalization. We have no need of intra-aortic balloon or ECMO, and very few cases of low output syndrome. This for in terms of a good repair and good myocardial protection. So the follow-up is very good. We don't have valve mortality in the follow-up, and in 98% of patients at 5 years, this was completed 5 years. This follow-up, the patient had no mitral regurgitation or trivial. So individualized approach may be helpful to optimize the repair rate, and with this very nice echo assessment in the operating room, and with very exceptional echographist in the operating room, we can reach maybe 99% of repair rate with a very low complication rate. And this is the incision. What we can share is that the experience need, of course, some training and tutoring. So surgeons that want to go from sternotomy to minithoracotomy should have a proper training and the tutoring while starting. Otherwise, it's easy to start, but then to have some very bad, heavy complication and to abandon the technique. This technique is very very helpful for the patient, but it's very also nice for the surgeon and for the surgical team. And it should not be abandoned if a proper training is followed. This is the team from San Gaudenzio, and the result depends from not only the chief, but all the team. It's a very strong team, and I want to thank everybody of the team is still working there and somebody with me for this very nice experience. Now I have also a short video of 5 minutes if you want of sternotomy, minithoracotomy. If you want, I can show. Otherwise, we can move to the other presentation or to the question. Let me know what you want to do.
It's okay.
Question, please.
You can start your video if you want now.
Yes.
And the question after that. It's okay? Like that?
Yeah.
Ok,
ciao Marco. Marco.
Yes,
ciao ciao, piacere rivederti almeno così.
My pleasure, Horia.
May I ask you some comments on that until you put the other video? Because there are students, they should also know that the mini-invasive or limited approach in minithoracotomy or robotic surgery implies the cannulation of the femoral vessels or sometimes of the jugular vein and so on. And you have some possible complications at the access site as compared with a classical approach in median sternotomy. And if you could comment on this a little. And then regarding the costs of the operation.
Yes.
The classical versus, yes.
Yes, this is very nice question, Horia. And of course, when we do the minithoracotomy in the first period, we did percutaneous venous cannulation with a single cannula and also a direct aortic cannulation through the incision. Then now that we move to total endoscopic, we need a femoral cannulation, and we do a small incision, a femoral cannulation. And this is mandatory if you want to do a total endoscopic procedure. The cost is quite low because, of course, the system, the instrument costs a little bit more, but is much cheaper than a robotic system. And you should know that we can spare blood in terms of cost. We can spare blood and hospitalization, time of hospitalization. So the total cost is even less important, and also rehabilitation. So the total cost is less important. It's cheaper to go on minimal invasive, although the instruments are a little bit costly. And you know that we don't use the intra-aortic balloon. It's very expensive, and so the real cost is really low. It's not different really from sternotomy. Maybe is even cheaper. Can you see the video?
Yes.
So now this is a video prepared by our colleagues to compare the sternotomy. This is a previous experience that this was very important to move to, maybe you didn't catch, this was a direct aortic cannulation and the cross clamping. This is the aortic cannula, and the cross clamp with the flexible chignette clamp is this was made under direct vision. You see, this is the clamp. And this is the anterior cardioplegia. So the aim the first time and also now is to reproduce the same technique as sternotomy. That means direct aortic cannulation, direct aortic cardioplegia, and to simplify the technique. In 2001, we presented how to minimize the learning curve by this sample simplification. We use a single endotracheal tube.
Sorry, doctor. Can you go full screen, please?
For?
So full screen, so we can see better.
Full screen, if you want, yeah, of course. Sorry. Voila. And maybe I have to go back. Anyway, and so this is the minithoracotomy approach: direct aortic cross clamping and direct aortic cannulation. So we wanted to reproduce the same way of myocardial protection. That means direct aortic cannulation and direct aortic cardioplegia with custodial del nido, and with a single endotracheal tube and a single double stage venous cannula inserted through the femoral axis, going up to the superior vena cava. And we use the same cannula, single cannula, also for tricuspid surgery. So you see, this is sternotomy, of course. This is minithoracotomy. And at the end, the visualization of the valve is even better in minithoracotomy because we can see the valve also on the screen, the big screen, and the operation is the same. If you see this for student, the operation is the same. This is a standard instrument on the right, endoscopic instrument on the left, but we didn't change the surgical technique except the access. This, I think, is very important in the training and the tutoring of a surgeon that want to move from sternotomy to minithoracotomy, that they should reproduce the same operation, simplify the technique to reproduce the same operation that they have done before, performed through sternotomy, to avoid complication and to avoid recurrence in mitral regurgitation. This is the reason why we prefer a complete ring. And you can see we do the same operation. Here's this artificial cord inserted in sternotomy. This is artificial cord for anterior leaflet inserted through minithoracotomy. And big advantage nowadays with the recent 3D endoscope is that we can perform this operation totally endoscopic without a robot and with the video better than this one because we have a high definition full HD 32-inch screen. So the magnification and the definition of the screen is even better. So this is what we can say to the young generation that want to move to this surgery. But please, very important message, not do it by yourself. Follow a training, follow a tutoring, as we did 10 years ago, 12 years ago, because otherwise you may have problem. And we didn't want to have problem with this kind of surgery. And this is the reason why in Mitral Conclave in 2011, they accepted our presentation how to minimize the learning curve for moving from sternotomy to minithoracotomy. This is very, very important to have very good results. If there are any questions, please go ahead.
Yes, we have some questions. Any contraindications on patient selection for sternotomy?
For sternotomy or minithoracotomy?
For sternotomy.
I can interpret this question. So if you have a very calcified ring, we don't use minithoracotomy. We go on sternotomy. If you have very complex valve, we since many years we perform the operation through minithoracotomy. So it's not a problem of complexity of the disease. We can repair the valve with the leaflet prolapse. We have repaired more than 350 Barlow valves through minithoracotomy. We don't use minithoracotomy if the patient has had, for example, very diffuse calcification of the ring, or if there is maybe the problem of thorax access. If the patient has a strong adhesion on the minithoracotomy, we prefer to move through sternotomy. Otherwise, all the patients are operated in a regular base through minithoracotomy.
Okay, thank you.
If there are any other questions.
Yes, I had a curiosity. I read in some studies that the leaflet tissue may have contractile properties. Is that correct?
Could you repeat the question?
We didn't understand. Which tissues?
The leaflet tissue.
The leaflet tissues have also contractile properties. They also have a very rich innervation. And the newer studies are directed towards the complex definition of the mitral and the aortic valves, so the atrioventricular and the arterial valves, that are very much more complex structures. They are living elements of our heart. So they receive vascularization directly or indirectly. They receive innervation. They also have some contractile elements in them.
Okay.
Any other question? Any other question?
One more question. In case of valve replacement, does it have better outcomes if you preserve the papillary muscles?
This is a very good question, because we have experienced since 30 years that preservation of the leaflet reduce the complication rate and also allows a better preservation of myocardial contractility. So in case of rheumatic very calcified or fibrotic valve, we prefer to replace the valve, and we preserve posterior and anterior leaflet. So we preserve, and it's better to preserve the connection between the leaflet and the ventricle. So it means to preserve the natural cord from the papillary muscle to the leaflet. In those cases, we open the anterior leaflet, we resect the anterior leaflet, but we keep the cord, primary cord from the anterior and posterior leaflet to preserve in time the valve ventricular continuity and valve ventricular function. This is very important. I think Horia is a master of this concept. Horia, do you agree?
Not only me, even in the old times when they did the classical mitral valve replacement, in almost every case, they tried to reinsert some cords on the mitral prosthesis and so on, or to perform the papillary muscle sling to keep them close to each other, to avoid the spheroidal left ventricle deformation and so on. So this is a sine qua non for the mitral valve repair.
Absolutely.
Okay, thank you very much. I think that was the last question for today. So in conclusion, I want to thank you, doctors, for your time. It was a great honor to have you here, and thank you for these amazing presentations.
Hope you enjoyed
Very
that.
much.
Thank you.
Thank you to you. It was very, very nice meeting. We are in very international meeting, but I can say that the level of your presentation outstanding that needs a very, very diffusion of this webinar. Thank you. Thank you.
We are waiting for the feedback of the people participating.
Of course.
Very important for us to have the feedback. Thank you.
Of course. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye.